So next talk will be by my co-chair, Professor Andrew Chang, and he's going to talk about endophthalmitis vitrectomy. And he's going to also show a video, a case, right?
Yeah, that's right. So if you can bring up my first talk, Mary talked about learning from your mistakes, and this happened to me last week. So I had the video made up quickly so I can show you what happened and what we did to get out of it. We are seeing more and more, and I think you've noticed this, more and more dislocated lenses. And furthermore, our anterior segment colleagues are trying to manage these more and more using Yamani style or like a cow hitch to try to hold it. And what we're finding is that these eyes have had capsular tension rings, and so the whole complex falls backwards. But this is a case that I managed last week, and the title says subluxed IOL and sutured IOL and sutured again, and I think you probably can guess what happened here. So the case begins, he's had multiple surgeries, and the plan was to do a 4-point fixation Gore-Tex sutured IOL. Here was setting everything up. We're using 25 gauge, but I know that ultimately we'll be moving to 27 gauge. This is a plate lens that has fallen in the back of the eye, and we then were able to retrieve this. There's really no point here in fixating this lens, so it's explanted. We are now using an IOL that has 4-point fixation. Gore-Tex is used, and because of the 4-point fixation, we find we've got greater stability. Here it's been put in, and I'm just now tying up the Gore-Tex. We've closed the wound, and then this happens to me. Oh, the Gore-Tex suture breaks, and the whole lens is now tilted back into the eye. You can see how it looks now. So we then started threading another Gore-Tex whilst the lens is inside the eye, and we were able to retrieve this situation. So the options would have been to take the whole lens back out again, but this does happen. And why does it happen? Well, I think that as we're using here max grip forceps in order to pick up the lens, and as we use it more and more, we must remember that they are disposable, and so the tips get caught. So as I was burying the Gore-Tex suture at the end, it probably didn't let go. And as I moved up, it actually unraveled Gore-Tex, because Gore-Tex can't be broken, but I've clearly unraveled the suture. So we might talk a bit more later about techniques that we are using and what's available for us now and for anterior segment colleagues to deal with. We've talked about drop nuclei and other situation. Can I have my next slide? Oh, thank you very much. So this is absolutely devastating, and we are seeing this not only following cataract surgery or other intraocular surgeries, but also increasingly with intravitreal injections. And I know in India you have an entirely different spectrum, but this is an Australian perspective. These are my disclosures. So the title of this symposium was Dealing with Complications Following Ocular Surgery. Well, this is the one that we fear most. And these are the 5 cardinal signs of infection. And it's important to remember this because sometimes you will see other diagnoses like a TAS or uveitis or retained lens matter. And so we'll be faced with a case where we'd be worried that there's an endophthalmitis and what to do. And I think what we do in most cases, we treat as for an endophthalmitis because it's devastating if we do not give antibiotics. So unfortunately, this is a patient who developed endophthalmitis, and it was actually his only eye. And we were not able to save the eye despite surgery, and then our oculoplastics specialist ended up removing the eye. So who gets endophthalmitis? Well, it's fortunately very rare, but there are patient-related factors, and that previous patient had very, very disorganized eyelids and scarred conjunctiva. There's procedure-related factors such as clear corneal surgery, or when there are complications such as unplanned anterior vitrectomy. And surgeon-related factors you would think would be a factor, but trainee and increased time was not shown to be a factor in several studies. So we are now seeing, at least in Australia, a changing spectrum of endophthalmitis with increasing intravitreal injections. We are seeing a different type of bacterial organism. And we wanted to ask whether the outcomes of endophthalmitis following cataract surgery differs from intravitreal injections. And so here we present 100 eyes in 100 patients in two groups, 53 following IVI and 48 following cataract surgery. And the take-home message when we looked at the patients presenting to the eye hospital was there was a significantly increased chance of a streptococcus infection, much more common following IVI, and it was thought to be due to aerosolation of saliva, that is, not wearing masks whilst doing injections. And if you did get a streptococcus germ in the eye, you had a very poor visual prognosis, and your chance of an enucleation or removal of the eye was 17 times greater. So we have data, the endophthalmitis vitrectomy study, which guides us into how we treat endophthalmitis. But things have moved on. Technology is different, antibiotics are different. And I think in this country and in our region as well as in Australia, there is a trend towards earlier vitrectomy. And in theory, it allows debridement of bacteria and inflammatory debris, better diffusion of antibiotics, and in theory, more rapid visual recovery. So these are the technological changes, and if you go into the trade display, you will see that we've got 27 gauge. Dr. Mittal was doing 27 gauge. We've got better cutters, we've got better illumination and vision systems. Also, our anesthesias are changing, and access to care is much different now. When the EVS was done, it was probably harder to get into an operating room, but in this case now, I know our colleagues in the US and in Japan, they can get into the operating room very quickly because it's emergent. So these are the potential advantages, and these are, I think, quite intuitive, but there are challenges which include poor visualization, damaging the retina, accessing an operating room as well as anesthesia. So this is another study that we performed at the eye hospital in which we took patients to an operating room for vitrectomy surgery early. And the purpose of this study was to evaluate the efficacy but also safety of early vitrectomy in acute endophthalmitis. So here we looked at 64 consecutive patients during this time period, and at 12 months we examined the primary outcome, what their vision was, and whether there were any other adverse events or prognostic factors. So this is what we do currently. Immediately the patient is taken into the ED or procedure room to perform a tap and inject. This is done with local anesthesia. A 23 gauge needle is injected through the pars plana. 0.2 of a mil is taken out. Often this may be difficult, but that is the aim. And vancomycin and ceftazidime are given straight away, even if a theatre case is booked for several hours later. And then we aim to perform vitrectomy surgery as soon as it is possible, in this study within 72 hours. And visualization is an issue, so the corneal epithelium sometimes needs to be debrided. We need to wash out the fibrin and the hypopyon from the anterior chamber. The aim is to do a core vitrectomy, and we look for any tears that we might have caused, and this is treated. And we can talk later about whether to use gas or oil tamponade, and there is increasing evidence that oil tamponade may in fact be more effective in terms of antimicrobial effect. So here are the 64 eyes and the baseline characteristics, and you can see here that the mean time from onset of symptoms to a vitrectomy was 0.8 days. So they got into the operating room quickly. And if you look at the 64 eyes, they were mostly due to phaco or post-phaco as well as post-IVI. And if we looked at the bacteria in this study, most were still Staph epidermis, followed by Streptococcus and also Staph aureus. And these are the visual outcomes. So overall, the vision improved after they underwent a vitrectomy procedure, with 89% improving sight and 42% ending up with 6/18 or better vision. And when we looked at the patients who did better, the ones that were post-cataract did better, as well as those who were culture negative versus culture positive endophthalmitis. But there were complications, and this is what I'd like to talk about now. So about 10% of our eyes developed a retinal detachment, but there were other complications such as epiretinal membrane and hypotony, and in our series we lost 2 eyes. So I'll take you now through some cases. This is a patient who developed endophthalmitis following IVI, and it was pretty fulminant. You can see quite a purulent vitreous. There's material on the retina itself. It certainly does not look good. Sometimes the material that you see there could be the antibiotics that are often given straight away. Unfortunately, this patient about 2 weeks later developed a retinal detachment. So she did well after the vitrectomy, but you can see here there is early PVR. And in these cases, the retina was repositioned, and we used silicone oil tamponade once we treated the areas where the retina was necrotic. This is a patient who developed a Haemophilus infection, and we really thought that this eye was going to be lost. Again, very purulent vitreous. The consideration here is how aggressive are we in shaving the vitreous, and do we create a PVD? And in general, we are not aggressive in creating a posterior vitreous detachment, as you can create breaks. And we remove the vitreous as safely as we can, but the worst thing for us in this situation is to create a break. This patient did actually very well, but about 3 months later, you will see that she loses vision due to an epiretinal membrane, and this can occur following endophthalmitis. Here the epiretinal membrane is causing quite marked distortion and traction to the neural macula with a fold, but the membrane was able to be removed subsequently. This patient developed choroidal effusions, and this is one of the other things that ultimately causes loss of the eye in the longer term. Here there are large choroids on the temporal side. We're using the trocar system to try to evacuate the suprachoroidal fluid. We remove some of it and the rest comes out once we actually remove the cannula. And here then the choroid is reattached and we go on to perform a air tamponade. So in conclusion, what we found is micro-incisional modern vitrectomy techniques are effective in improving sight. We are considering, as many of us, whether the EVS is appropriate. We still do not have a randomized control study for modern management of endophthalmitis, but in particular post-IVI endophthalmitis. There are colleagues in the US and in Japan who are collecting data to look at retrospective data. There are a number of techniques for clearing the view, which makes the vitrectomy safer. The questions remain is how aggressive are we in performing the vitrectomy? How aggressive are we in creating a PVD? And the choice of tamponade. A number of our colleagues routinely just put oil into the eye and find the eyes do settle, but subsequently the oil needs to be removed. So whilst we can perform vitrectomy surgery, we also need to deal with the complications, and these are often significant and may be blinding. Thank you.
Thank you very much, Andrew. Any question from the floor? Would you inject any intravitreal antibiotics after putting gas or oil?
Yeah. There are, in theory, algorithms to halve the concentration, and we do that. We just give about half of it if there's a partial airfill or complete airfill.
I had one question, Dr. Andrew.
Yes.
If you're not having a retinal detachment on the table, would you still go ahead and put silicone oil?
I don't.
You don't?
No, I don't. But a number of my colleagues have looked
Yeah.
at the organism and the antibiotic distribution, and they actually feel that oil tamponade will concentrate the antibiotics next to the retinal space. Yeah.
And also, I think there was a paper published which said that silicone oil per se has some antimicrobial
Yes.
activity.
That's right. And
Yeah.
I think if you ask older colleagues around the time of the EVS, that was their general impression, that it was fantastic at controlling the distribution of the inflammatory mediators as well.
One question, what are your tips for fungal endophthalmitis? Sometimes you find that even after vitrectomy, forms membranes behind the iris and keeps popping out of the pupil. So it's very resistant, you know. Do you like to inject very often, and how do you give them good outcomes for fungal?
Well, this is what you're really seeing here in India. You see a lot more fungal endophthalmitis than we do in other areas of the world. I think that when we have cases of endophthalmitis, we are aggressive with early vitrectomy, and you may need to, as you've just indicated, continue to give antibiotics, but often you may need to go again to remove cyclitic membranes and inflammatory membranes. These are really challenging cases.
I think just to add to that, like fungal infection, as Dr. Andrew mentioned, they are very difficult to treat. There are a few things to remember that you have to be very aggressive. Like IOL has to really be sacrificed, at the first go of the vitrectomy. And also the fungal granulomas, they tend to, grow behind the iris because that's a dark, cool area. So that's where they keep fulminating. So I've myself treated a very bad fungal end off. Sometimes we also have to opt for cryo. And you have to actually do a cryo to the entire fungal granuloma. Oil is a good option in these cases. I think you have to be again more aggressive in putting in silicone oil in these cases. And lastly, when you're treating them with antifungal intravitreal injections, I think you have to be giving them at least once every 24 hours. So don't wait for 48 hours or 72 hours to repeat the injection, and especially when you vitrectomize the eye, I think the intravitreal has to be given every day.
So what I have realized is there are two types of managements in endophthalmitis. So one is in the acute phase of the endophthalmitis, and one is in which the eye is now quietened down and they're just doing vitrectomy for media opacities or the residual exudates. And I think in those cases which are chronic, which have become chronic, and just doing a vitrectomy and no oil or no gas may do. But in acute phase, so there's no middle approach. Either you just do a core vitrectomy and put in intravitreal antibiotics, or you have to go all out. You have to induce the PVT, you have to put in oil and give intravitreal antibiotics. Otherwise, the problems of retinal detachment and necrosis, they keep on occurring post-vitrectomy surgery. What is your take?
No, that's a very, very good point. So if we're in the acute setting and the visualization is difficult, then often in the acute setting there may not be a PVD. If you're lucky, there's a PVD already because the patient's older anyway after IVI. But say it's a diabetic patient or somebody younger, it can be very hard to separate the vitreous. I don't aggressively chase it, but if it comes, then that's very good. I'm like you. I think you should try and clear it as much as possible. But in our studies and guidelines, and what we tell the fellows is the core vitrectomy is not really just a core. It's actually as much vitreous that we are able to remove what we believe safely within the limits of what we can see. And I completely agree that there's a second phase. Yeah. And the second phase is epiretinal membrane vitreous opacity. In the context of IVI, this does raise a consideration regarding the half-life of IVI injections. That is, whether the drug is still durable. And so that's a consideration, as well as the fact that whether you would go in again and continue IVIs, because patients often won't agree to that.
Thank you.
Do you prefer sending PCR for fungal and bacteria panel in each and every case, because most of the times the culture and gram stain, most of the time it comes inconclusive and you're really confused. So do you advise doing it in all the cases? Get a better idea.
Oh, well, in our series, 2/3 were culture negative. So completely agree. I think if we have now techniques to identify the germ, then you know where you are. And fungal is hard to diagnose. You really need to get the specimen across, and a really good microbiology department.